Thanks for that introduction. I wanted to talk to everyone today about eosinophilic esophagitis, or EOE as I will refer to it for the rest of the lecture, because I feel like a lot of GI doctors are a little bit confused by it. So I thought if we are, then maybe you guys might be as well. So a good way to learn about this condition. Okay, no disclosures. So by the end of this talk, I would like for everyone to be able to recognize the presenting symptoms of EOE, explain how we diagnose the condition, and compare the different treatment options available. I thought I'd start with two of my patients, just to give you guys an idea of how the different age groups can present. But this was a little 14-month-old girl that I saw with a history of reactive airway disease. She came to see me with a 2-month history of vomiting a few minutes after eating. The food could be chewed, partially digested, and really from a GI perspective, she had had reflux as a baby that resolved after a few months. She had been put on soy formula for concern for milk protein intolerance, but really was on cow's milk by the time I saw her. Normal weight and development. Mom's other main concern is just with the vomiting. She wasn't wanting to eat as much, mostly wanting to drink. So with this story, I did start off with a chest x-ray because I have seen kids before with this history that actually had a foreign body stuck in their esophagus, but that was normal. So then I scoped her, and this is what I saw. So you don't see any of the blood vessels, so there's edema in her esophagus. That bottom picture on the left, there's kind of lines going down, that's called furrowing, and all these white exudates. So these are classic findings of eosinophilic esophagitis. With her just oral aversions that she was having, we opted to start her on pharmacologic treatment. And then this might be a case that you guys might be a little more familiar with, because this is kind of a typical case. But a 16-year-old boy, history of ADHD, came in to see me with multiple month history of feeling like food was just getting stuck when swallowing. Carbohydrates, so bread, pasta, rice, that caused the most symptoms. He needed to drink a lot of fluids to get the food to go down. He was eating less, having to chew his foods for longer periods of time before swallowing. He had seen an ENT before me who had ordered him for an upper GI. That was normal. And so really with this history, I was worried for EOE, so we went ahead and performed a scope. And again, similar findings, edema and that linear furrowing. We discussed different treatment options, and he as well opted to do pharmacologic treatment. And we'll talk about all the treatment options later. But really, what is eosinophilic esophagitis? So it's a chronic disease of the esophagus characterized by eosinophilic inflammation and esophageal dysfunction. So you have to have those symptoms, so difficulty swallowing, food impaction, vomiting, things like that. And then on pathology, we have to see greater or equal to 15 eosinophils per high part field on multiple biopsy specimens. And then we also have to kind of think and make sure that I don't think there's any other condition causing the esophageal eosinophilia, because there are other things that can cause it. So really the clinical features can differ by age. So infants and toddlers, kind of like that 14-month-old, I saw feeding problems, vomiting, food refusal, those are the most common symptoms. Some children can have choking. If they're not eating as much, they might have failure to thrive as a presenting symptom. Older children can have dysphagia, choking, gagging. Food impaction isn't as common, but it can happen. But a lot of times they can have nonspecific GI symptoms, so belly pain, heartburn, nausea, vomiting. And then the older children or adolescents tend to have the classic symptoms that we think of. So saying that they're actually having food getting impacted when swallowing, dysphagia, but they can also have heartburn as well. And so really, how common is it? I feel like I see it all the time, but it's about 30 cases per 100,000 children. And the incidence and prevalence have been increasing worldwide. If you look at this, at these charts here, you'll see, kind of in the early 90s is when eosinophilic esophagitis was named as its own separate condition. Before we thought it was just reflux. But really, since that time, across the world, US, Europe, Australia, both the incidence and prevalence has been increasing, like many other conditions. And so when we think of EOE, most people think about it in adults, and the 30s is the most common age for it to be diagnosed. But you can see on this chart that it happens in every single pediatric age group as well. It's 3 times more common in males than females, and we tend to think of it as a disease that affects mostly the Caucasian population, but we see a lot of African American patients with EOE as well. This is a paper that came out of Children's National in Washington, D.C., just comparing the African American patients with EOEs, their presenting symptoms with the Caucasian patients. And you can see in the African American patients, they were more likely to present with failure to thrive and vomiting compared to dysphagia, food impaction. So it's important to realize, yes, we think about this as a condition that mostly affects patients that are Caucasian, but it can affect every ethnic group as well. And when we think about what causes EOE, like I mentioned, it's more common in males. It's also, there's higher risk among family members. We think about these patients having other atopic conditions as well, so we'll go through that in a minute. But there's also some genes have been identified. There's also environmental risk factors. So for example, patients that have H. pylori, chronic infections might be at lower risk than EOE because that activates a different pathway than EOE. In some retrospective studies, they've seen that patients who are born via C-section or maybe had antibiotic exposure earlier in life maybe have a higher risk for EOE. And so this was a study looking at EOE frequency comparing monozygotic twins, dizygotic twin siblings in the general population. So clearly from this we know that there is a genetic predisposition, as we see the monozygotic twins had the highest frequency, but also with it being in dizygotic twins as well, this indicates that there's genes, but also different environmental factors. And then again, there's higher frequency in siblings than in the general population. I think I just said that. And so we know that it is associated with other allergic conditions like allergic rhinitis, asthma, IgE-mediated food allergy, and eczema is more common in patients with EOE. And we also know that there can be seasonal worsening of symptoms. So for example, if you have a patient who has really bad springtime allergies, then maybe their EOE might flare up a little bit in the springtime, especially if they're not controlling their nasal symptoms. So that's why for my patients with EOE that also have allergic rhinitis, I want to make sure that they're seeing their allergist, that they're doing their nasal steroid sprays to kind of keep their nasal symptoms under control, because if you think about it, they're going to swallow mucus that kind of has those allergic antigens in it. It can cross the barrier of the esophagus and trigger inflammation. And then now that we have patients doing oral immunotherapy for things like peanut allergy, it's also important to know that a small percentage of patients on oral immunotherapy will also develop EOE during that treatment. And if they do have symptoms, they need to be referred to GI because they need to stop their oral immunotherapy if they develop EOE. And so this is just kind of showing where EOE kind of lands with all the other atopic diseases. And you can see here near the bottom, it's the red line on the bottom, and it kind of follows a similar pattern of allergic rhinitis. Usually it presents a little bit later in life, whereas compared to eczema, which I think we all know can present much earlier in life. And so how does EOE develop? We think it's, in a genetically susceptible person, there's different proteins, so whether it's from the food that they eat, whether it's from the microbes, whether it's from their allergic, the mucus that they're swallowing with different antigens in there, those cross the barrier of the epithelial barrier of the esophagus, and then that really triggers that Th2 cell pathway. Those release other interleukins that activate STAT6 pathway is really important, which increases eotaxin 3. Eotaxin 3 attracts eosinophils to the epithelium. And then in addition, that IL-13 in there, when that's activated, it kind of breaks apart the barrier between the epithelial cells, letting those antigens get through. And so over time, you have your inflammation, which can lead to that loss of that barrier function, and then over time we can have remodeling and fibrosis. And what I want everyone to pick up is that I did not mention IgE anywhere in this pathway, so EOE is not an IgE-mediated disease, and we'll talk about that later. So for patients with EOE, you start with your normal esophagus, you get this eosinophilic inflammation, And this is the ideal time to start treatment, because what can happen in some patients is that over time they can start to develop fibrosis and eventually complete fibrosis. And at that point, there's nothing that we can do from a medicine standpoint. Really, the treatment at that point in time is esophageal dilations, which we would like to avoid in all of our patients. So how do we diagnose EOE? So I see a patient, they have the clinical symptoms. Sometimes I will get an esophagram as well, just to make sure that there's no stricture there before I scope them, because if they have a stricture, I'm going to need to dilate them too. But they have their symptoms. I proceed with the scope, the EGD, and then we get our tissue samples, make sure that there's that eosinophilia there, the greater than 15 eos, make sure I don't think it's another disorder, and then I have my diagnosis. And so these are just the different findings on the scope that we can see. So edema in the top, furrowing on the, in that bottom corner, the exudates, you guys already saw all of these, but in the middle, we call that rings or trachealization of the esophagus. If you didn't know that was the esophagus, you might think you were looking down the trachea. And then in this middle picture on the bottom, strictures. Usually we don't see strictures as much in pediatrics, which is a good thing. And then the picture on the far side, that is a normal esophagus. On this side, this is one of my patients. I think this is actually from the 14-month-old. This is from one of our pathologists at Children's. But you can see over here, these blue cells going all the way up. That's basal cell hyperplasia. And I don't know how well you're picking it up, but there's lots of bright pink cells up there, and those are all the eosinophils. And so how do we treat these patients? Of course, like any condition, we have goals of treatment. So the main thing that the patients want is they want us to improve their symptoms. So dysphagia going away, if there's any food avoidance because of issues with eating, swallowing, all of that to improve. But as the doctor, I want to see improvement in the histology, so less than 15 eos, resolution of that basal cell hyperplasia, and also reduction in whatever I saw on the scope, whether it was exudates, furrows, edema, rings. I want to see that getting better to know that the treatment's working. And so what are our treatment options? We have pharmacologic therapy and we have diet therapy. And so first we'll go over kind of the most common medicines that we use. There was actually, we'll talk about at the end, a biologic that was just approved for EOE. So proton pump inhibitors are medicines that we can use to treat these patients, and we actually use what we call high dose therapy. So that's 1 mg per kg twice a day, up to 40 milligrams per dose. And so if I diagnose a patient with EOE, I'll put them on high dose PPI for 8 to 12 weeks and then reevaluate. And that's with symptoms and with scope. It can induce remission in about 42% of patients, and then of those patients, about 80 of them can remain in remission on PPI. So it's not a perfect medicine, but it can help a large number of patients. And none of these treatments I'm going to go through today work in 100% of the patients. So it doesn't work just by blocking acid, it also works by inhibiting those pathways I talked about earlier. So it blocks that STAT6 pathway so that we don't get activation of that eotaxin 3, so we don't get eosinophils going to the esophagus. And then this is an older study. I know there's lots of different labels up there. It used to be that we thought patients that responded to PPI were different than EOE, but now we know it's just a phenotype of EOE. But what I want you to pick up from here is, on the far side, this is the patients that were treated with PPI, and their gene regulation after PPI treatment looked more like patients that did not have EOE or reflux, or looked like patients with reflux. And if you haven't looked at something like this before, red means that the genes are upregulated, blue means that the genes are downregulated. So you can clearly see from the middle two columns that in EOE patients, they have a different gene regulation when there's active disease compared to normal patients in GERDs, and PPI can reduce that or switch that up. The other main drugs that we use are swallowed steroids. It's an accepted treatment in kids and adults. Right now, we don't have any special formulations specifically for EOE available in the US that are approved by the FDA. Europe does have a formulation that's specific for EOE, but currently we use it off-label. And the two options are fluticasone inhalers, and the dose is there, depending on, of course, the patient's weight. Or we use budesonide respules, and basically you have to open it up. The patient has to mix it with something sticky like honey or pancake syrup so that it sticks to the esophagus, and then they take that twice a day, and the dose is based off of weight again. And really, they can't eat anything for 30 minutes or drink anything because we want the medicine to sit on the esophagus. I prefer to use budesonide just because a lot of our patients also have asthma, and I think that that's confusing to tell them to inhale for asthma and swallow the medicine for EOE, and so that's why I typically use the swallow budesonide respules. Of course, there are side effects that we get concerned about. So we do see asymptomatic candidiasis in up to 5% of patients, but luckily no evidence of decreased growth, which I think all of us are concerned about, and really clinically significant adrenal insufficiency is really rare. So overall, safe to use for these patients. And this is just from 2 years ago. It was just a meta-analysis looking at the different published studies that were out there. And overall, the efficacy rate of swallowed steroids is about 60%. So again, not perfect. So if the patients don't want to do medicine, or let's say medicine doesn't work for them, we also can do diet therapy. And there's different types of diets out there. Technically, the one that works the best is using an elemental formula. So this is basically, this is a very old study, but basically it was the first one that showed if you put a patient with EOE on an elemental formula, you have a significant decrease in their eosinophil counts. And then this study is a little bit older, 8 years ago, but still, it was a meta-analysis looking at the efficacy of elemental formulas, and it's about 90%. But really, we don't use it that often because, as you guys know, they don't taste very good. What 16-year-old male wants to be put on an elemental formula? They're not cheap. Currently, they're hard to find, and it can cause social isolation. So really, we don't use this except in more extreme cases. But if I had a baby, it could be a good therapy. So really what we do is this food elimination diet, because we know the common food triggers for EOE are milk, wheat, egg, and soy. And so we do this empirical elimination diet. And there's different ways to do it. You can take out one food at a time, 2 foods, 4 foods, or 6 foods. The efficacy increases with the more foods that you take out. You can use a step-up approach, or you can use a step-down approach. It really just depends on your patient. You need to pick the plan and really stick to that plan. So as long as you're organized, you can do either one. And really for this, what we do, the idea would be is that we would take the foods out. I have to do another scope to see if they're in remission. If they're not, okay, diet therapy is not going to work for you. But if they are, then we start adding foods back in with the idea of seeing if we can find what that patient's food trigger is, with the idea that by the end of it, they might be avoiding a few of the foods, but hopefully not all of the foods that we removed in the beginning. And then people always ask about allergy test-directed elimination diet, so basically using skin prick testing to do that. So this evaluates for immediate food hypersensitivity, so foods you're going to have anaphylaxis to, so IgE-mediated food allergy. And so for EOE specifically, it has a very low positive predictor value, so we don't use this anymore. They used to, probably even just 5 or 7 years ago, some people were still using this technique, but we don't anymore. We do use it if we're going to take foods out of the diet to test specifically for the foods that we're taking out, because if the patient has a positive test to it, when I reintroduce the food, they might need to be tested again, because if the skin prick test is larger, they might need to do a food challenge in the office for the reintroduction. So that's specifically testing for the foods, those 4 to 6 foods that we know we're going to pull out. But otherwise, we do not use this test to decide what foods to pull out. And I can answer questions later if that doesn't make sense. And then luckily in the last few months, a biologic was just recently improved. And so this is just a slide to kind of go over again all of the different pathways that biologics can try to target in EOE. And this is a slide, or this is a chart from a study published earlier this year, kind of going through all of the studies going on currently for biologics in EOE. And we're going to focus on dupilumab because that one was actually just approved. So basically it blocks part of the IL-4A receptor, and so by doing that it blocks IL-4 and IL-13. I just went through that. And it's already approved to treat atopic dermatitis down to 6 months of age, asthma, chronic sinusitis with nasal polyps. And it was approved for EOE ages 12 and up with a weight of at least 40 kilos in May. Last month, they released very promising phase 3 data for patients 1 to 11, so hopefully soon it might be approved in this younger age group. And the dose is 300 milligrams sub-Q weekly. This is the phase 2 data that was released for dupilumab a few years ago, and you can see symptoms significantly improved, the histology findings, so less than 15 EO significantly improved, and the endoscopy findings, so going from an abnormal esophagus to a normal esophagus when we looked during endoscopy. And then this is phase 3 data that was presented at the Quad AI conference earlier this year, so from one of the abstracts. But again, so this is from the larger phase 3 study, again, showing all of these same things. Decrease in the eosinophil count, improvement in the symptom scores, improvement in the scope findings grossly. So how do I treat these patients? Currently, we don't have guidelines as to where biologics will fit in. I tend to think of a patient that maybe has eczema, maybe has horrible eczema, poorly controlled asthma. Maybe that patient is a good candidate to start a biologic up front because you could treat multiple diseases with one drug. Or maybe a patient who has a family history with multiple other family members having strictures and things like that. Maybe you might want to opt for a biologic early on. But really, whatever we do, whether it's high-dose PPI, diet therapy, or swallowed steroids, or a biologic, you start them on that treatment, and you really need to reassess 2 to 3 months later with a repeat scope and their symptoms. And if they're not in remission or they're not improved, then you might need to move on to one of the other different treatment options. Of course, always reassessing, did the patient do the treatment, adhere to the treatment that you asked them to, because that happens as well, where maybe they weren't taking the medicine in the exact correct way, and maybe that's why they're not in remission yet. And so we at Children's Hospital in New Orleans, we have a multidisciplinary approach to treating these patients where I am involved as a GI doctor, Dr. Abrio for allergy and immunology, and we also have a dietitian involved in our clinic to help with the patients doing dietary elimination. And we have our half-day clinic once a month where we see patients who are complex cases that already have a diagnosis of EOE. So we don't work patients up in this clinic, but we see either complex patients from within our own hospital or second opinions from outside. And that's it. Thank you.